Morning, colleagues and distinguished guests. Apologies for the delay in starting. Our moderator is currently having challenges with logging on, so I will take over the role in the meantime while she joins us. On behalf of the Academy of Science of South Africa, I would like to warmly welcome you to this webinar on typhoid fever in South Africa, lessons from recent outbreaks. ASAF, as the National Science Academy, is committed to providing evidence-based advice to inform policy, strengthen health systems, and support responses to pressing public health challenges. This webinar forms part of that mandate, bringing together leading experts to reflect on recent typhoid outbreaks and to explore how science, policy, and practice can work together to strengthen prevention, surveillance, and response. Although South Africa has a relatively low overall incidence of typhoid fever, recent outbreaks in areas such as Hammanskraal and Bronkhorstspruit remind us that vulnerabilities remain, particularly in relation to water safety, sanitation, antimicrobial resistance, and disease surveillance. Today's discussion is therefore timely and important as it highlights the need for sustained vigilance and a strong One Health approach to protect communities and prevent future outbreaks. We are privileged to be joined by an excellent panel of speakers. We have Mr. Phuthi Sikwadi from the National Institute for Communicable Diseases, who is a public health professional with nearly 8 years' experience in enteric disease surveillance and outbreak response. His work focuses on pathogens such as Salmonella, Shigella, and Listeria, and he's actively involved in outbreak investigations and epidemiology training. Our next speaker is Dr. Eunice Ubamba Jaswa, Research Manager for Water Research Quality at the Water Research Commission. She is a microbiologist with expertise in water quality, emerging contaminants, and public health. She leads research on source water protection and has published extensively in this field. Over to you, Eunice.
Morning, everyone. Thank you so much, Kutso, for the introduction. I hope you can hear me clearly.
Perfect, thanks, Eunice.
Okay, great. And can you all see my slides?
Yes, thanks, Eunice.
Okay, great. I think I'm just going to switch off my video as well, just to make sure that we save bandwidth. Okay, great. So as Kutso mentioned, I was invited by ASAF, and thank you so much, ASAF, for that opportunity to talk about water quality, emerging contaminants, and public health risks, and looking at it in terms of implications of that to typhoid fever, and in particular, its prevention within South Africa. So I just wanted to give just a brief overview of the Water Research Commission for those who might not know about the Water Research Commission. We were established by the Water Research Act of 1971, and our core aim is really to guide, promote, and fund water research. So obviously, in terms of water research, and particularly for this presentation today, we are thinking about drinking water quality and also sanitation as well. So along that knowledge value chain, the main core is to fund research. We fund all across the country. We fund both academic institutions as well as SMMEs. We fund NGOs as well. And apart from funding and stimulating water research, we also enhance knowledge and build capacity within the sector. So for today's activity, that is what we're really doing, sharing the research that we have funded and making it applicable, like Kutso says, to stimulate policy development, and also obviously a multi-sector approach to some of the water issues that we are facing in the country. Okay, in terms of typhoid fever and water, I kept the background very simple because I knew that Puti was going to start off with the presentation, but it's basically caused by Salmonella typhi, which is a bacteria. It's spread via your contaminated water, contaminated with feces, or obviously also food as well, contaminated with feces, and it's strongly linked to unsafe water and sanitation. So the places where you're going to find the highest risk is where untreated water is used and where sanitation is inadequate. So typhoid fever is actually preventable. It's not one of those diseases that can be prevented. It can be with safely managed drinking water, as well as access to good sanitation. But I think, like Kutso mentioned in her introduction, some of the recent outbreaks highlight there is obviously some break in transmission. So when it comes to wash issues, we know that the disparity between South Africa is not the same. So you do have places where wash infrastructure is really, really good, and you have other places where wash infrastructure has deteriorated, particularly when we look at our peri-urban areas where we know there's very high vulnerability there. But the research evidence has shown that if you do have access to microbiologically safe drinking water, that is the most effective way to prevent typhoid. And in terms of generally, when we talk about water quality management, we know that having effective water quality management results in you having improved public health as well. So I just wanted to talk about drinking water regulation and oversight in South Africa to just bring a different perspective in terms of what our guidance is. So we have Department of Water and Sanitation, who is the provider of water. And then guided by that is the South African National Standard for Drinking Water, which is SANS 241. Based on that standard, water service authorities are supposed to provide water at that standard, and municipal water treatment systems are also supposed to adhere to that standard as well. And consumers are then supposed to receive water that is treated to that standard. So it's not a guideline. Guidelines are information that you can pick and choose to use, but because it's a standard, it's a required procedure that has to be followed, and it's legislated as well. So what does SANS 241 covers? So it applies to our drinking water specifically. So we are not talking about water for other uses. And we do know that water for other uses also has a potential for spread, but SANS 241 directly addresses water for drinking. And as I mentioned, it applies to municipal water. So you do have some municipalities that will provide water. You have bulk water providers such as your Rand Water and Mgeni. They all have to adhere to SANS 241, but also emergency supplies. So tankers, boreholes, any water that is supposed to be for drinking must be compliant to SANS 241. And the way in which the department monitors this is through the Blue Drop program. The key SANS 241 parameters that are useful for typhoid is looking at E. coli. So we use E. coli as our fecal contamination indicator. And then we look at total coliforms to ensure that the system in general has integrity, to make sure that whatever drinking water treatment system you are using, it is functioning well. Then from an operational point of view, turbidity is what we measure in terms of looking at our treatment efficiency for our plants. And then free chlorine indicates how much is available for the pathogen. So there is not a set standard for Salmonella typhi. We still use E. coli as our indicator. And if obviously there is more than one E. coli, then we go on to now start assessing what other pathogens could be present. So I wanted to also just bring in the fact that apart from the issue of SANS 241 and municipalities having to adhere to that, or any water service provider having to adhere to that, you do have instances in South Africa where people do receive water that it's been treated of good quality and adheres to SANS 241. But unfortunately, because of storage, the degradation of water happens over time. And I think it's a key thing that we have to think about when we think about typhoid spread or spread of any other waterborne diseases, that consumers might receive water of good quality, but because of how they store it and how they use it, then you do have microbiological degradation along the line. And we have a recent study that has shown that. It's currently still ongoing. It's to finish in March 2026, but it was looking at behavioral interventions that can be used for improving water storage practices in households such as Crabble. And it's a very interesting study because it does show that the municipality is supplying water that is of a good standard, as in it meets SANS 241, but you still have this huge diarrheal incidence that's occurring in the population. And it's because of a number of reasons. And some of the reasons that we found out is that behavior is really important. So you think about no hand washing with soap, not cleaning the container, not having a cover on your container, scooping and drinking from the same cup. If we think about fecally contaminated water, so they might collect water that's of good quality from the pipe, but then because they're using a scoop and drinking, introducing contamination, you could get spread of waterborne diseases. And ironically too, there's also a very low trust in the municipality. So the municipality still has to do a lot of work in ensuring that the households know that they are actually receiving water that's of good quality. So typhoid prevention spread is not just about drinking water quality adhering to SANS 241, but it's also looking at these types of behaviors and how to cut transmission pathways as well. Then I just wanted to talk about generally the water quality challenges in South Africa, and this is a summarized version, obviously pinpointing challenges that are important to typhoid. So we look at informal settlements and rural areas which are most vulnerable, and informal settlements, the vulnerability spreads in terms of what is happening. So for instance, if you have very extreme weather, if you have a heat wave going on, then the vulnerability will increase. If you have flooding, for instance, then the vulnerability also increases in those kinds of areas as well. So think increasingly peri-urban areas even sometimes are more vulnerable than our rural areas as well. The surface water is often contaminated. So if people cannot receive piped water, they might choose to use surface water, which we know definitely does not comply to SANS 241 or is not fit for purpose. And in this case, it's also likely to be contaminated. And the reason why most of the time it is contaminated is because of wastewater treatment works. We are increasingly experiencing the fact that our wastewater treatment works are either working over above the amount of volume that they're supposed to treat, or else the technology that is there is old and it's not treating exactly what is in our wastewater. Another huge concern too is intermittent supply. And I think intermittent supply is something that we have experienced all over the country now. Even in urban areas, you do find that there are now periods of time where there's no water, and the public is not really educated on how to deal with that. You know, you just get advice saying, go and collect water from a tanker that is situated in your area. But how do you store that water? How do you make sure that there's no contamination happening in the water that you're storing? So even in urban areas, there is a risk there too as well, because the best thing is obviously to get water directly from a piped source. And then you also get frequent contamination of water used for domestic purposes, just due to behavioral issues, like I mentioned in that project that we're currently doing in Crabble. So in terms of water quality, one of the new, or let me say emerging things that have come out is also looking at contaminants of emerging concern. And these are contaminants that come from various processes, be it agriculture, industrial, all our household activities, and everyday use of chemicals leads to now this group of contaminants that previously we have not looked at and don't necessarily have guidelines for. I think what's also important for CECs is the fact that it comes from various sources. So in as much as we might have contamination that comes from a point source, we know exactly where it is. With CECs, it's the diffuse pollution. So it's sometimes very difficult to track where they come from. So just to give a brief overview for those who might not know much about CECs, but CECs, like I mentioned, are pharmaceuticals. So your all the drugs that you take regularly, antibiotics, pesticides, your personal care products that you use on a daily. And then obviously, I'm sure quite a number of us have heard about microplastics. PFAS is a big one now that is really, there's a lot of work around that and a lot of research that has come even within South Africa as well. And then antimicrobial resistance as well, which Kutso also mentioned at the beginning. So in terms of CECs, they are not regulated in drinking water currently, and globally, there are very little CECs that are regulated anywhere. We do now have examples of microplastics that are being regulated by San Francisco drinking authorities, and then we also have PFAS that has just come into place with the EU Drinking Water Directive, which I'll just talk more about. But we know that in South Africa, the research that we are funded in by the WRC shows that they are in our water sources, and they not only are they there, but they signal the fact that we are having breakdown in wastewater and sanitation as well. CECs are chemically diverse, and then on top of that too, they occur at very, very low concentration. So having very expensive equipment and the sensitivity that you need makes the process quite costly in terms of routine monitoring as well. Then in terms of their persistence in the environment too, I think what is key is that they behave differently across your water, sediment, and soil. So that means that it's also difficult to monitor them as well. And then I also mentioned about regulatory uncertainty. So globally, it depends on where you are, what is happening in your catchment, what your land use activities are, and that is what is guiding whether certain CECs are going to be monitored or not. So like I mentioned earlier, on the 12th of January, PFAS, which are known as forever chemicals in drinking water, are now being monitored across the European Union. And what they've been really able to do successfully is to have an harmonized method. That means that whoever is measuring for PFAS across the European Union, basically there is one method that they're using, and then they can now define what their limits are going to be. So I think that is a very important move, and it's something that as a continent and as a country, we also have to look at as well. But in terms of us in South Africa, the Water Research Commission has funded work around the Knowledge Hub. So we started work trying to have a place where all information around CECs that we're monitoring could be placed. We funded a first phase from 2020 to 2023, and now a second phase is also continuing, where we're looking at data integration, trying to make sure that we refine the platform, and then also making sure that more stakeholders engage with it. And I think really the crux of the matter is to make sure that information on research that has been conducted when it comes to contaminants is readily available, to make sure that we don't duplicate research, and also to ensure that as the data becomes more available, there is a place to store that information. So in terms of the African continent, recently the Integrated Environmental Assessment and Management Journal also called for papers looking at CECs in African environments, and we got a number of submissions from South Africa, and it just illustrates the type of work that is going on in terms of CECs. I think South Africa is doing fantastic work around that. The research is there, but obviously moving it now from research to guidelines to set limits and then to policy is where we want to move to. So this is just to illustrate some of that, and just to pick up on some of the antibiotics that are obviously very relevant when it comes to prevention of typhoid, like your amoxicillin and so forth. So I would encourage you all to check that out. It is it's open for public, no subscription needed there. So in terms of CECs, why do they matter for public health? I do want to stress that CECs do not directly cause typhoid, and Salmonella typhi is not a CEC. But what CECs do is that they promote antibiotic resistance. So we do have a number of antibiotics and antimicrobials in general that are classified as CECs, and obviously this makes it difficult to now treat typhoid if you're picking up resistance patterns as well. And then for some CECs, for instance, like your microplastics, some of the research work we've seen has shown that you have microbiomes that exist on these CECs, and then they encourage AMR, and obviously then you have transmission of AMR from source to different components of your water. And obviously, if now surface water is used, then there is more opportunity to get disease. So there is still the need to keep an eye on CECs as we keep an eye on our regulated pathogens. So what we did also in the WRC is to fund our water quality guidelines, basically making it more of a risk-based tool in order to now pave the way to include some of these CECs that were not measured previously. So I think just to round off infected monitoring programs, what should they really have? They should ensure compliance with SANS 241, detect contamination as early as possible, and that means you're sampling across the whole system, source water, storage water, tankers, and from a risk-based perspective, if we think about households that are using treated water but storing it, that means that more surveillance across there as well, support outbreak prevention and resource, and then monitor. Monitor is mandatory. So in terms of SANS 241, there's no compromise there, but you can introduce other additional parameters as well and align it with water safety plans. So linking water quality and health surveillance, we want to integrate water quality data, typhoid case reporting. We want to enable early warning and targeted interventions if we know that there is an outbreak. Then in terms of some of the things, it's just some thoughts around how we could best link it. When we think about water quality data, the use of citizen scientists for different collection of data is really is on the fore. So I think that is something that we could also look at. In terms of health surveillance, tools such as earth observation are being used, and then also wastewater surveillance as well. And then when we talk about our integrated analysis, we obviously need infrastructure that has high performance computing capabilities and open source. We also need to understand the role of ethics in this process, and then financing as well. So I think just to conclude, I think safe drinking water is central to typhoid prevention. SANS 241 provides a strong risk-based framework for that. And also CECs just highlight the fact that there's a broader system issue, especially when we talk about unregulated upstream sources. And South Africa has strong standards, but effective implementation, maintenance of wash infrastructure, monitoring and integration is key and is the sustainable solution. I just want to invite you all to please check out our website if you do want to read more about our projects and the reports and associated publications that we have available. Thank you so much.
Thank you very much, Dr. Yabamba Jaswa, for a very interesting presentation. You can see, I hope, the reactions that you are getting from the audience. We really found that very informative, so thank you. Can I ask Mr. Sekwadi if you are able to try again your presentation? If it doesn't work this time, we'll move on to our third presenter. But Mr. Sekwadi, please try and take over and do your presentation now, if you can. Thank you.
All right. Thank you, Chair. And should I just continue from where I left? Shouldn't start from the beginning?
I think try to start from the beginning. I don't think people heard well. Thank you.
All right. All right, thank you. Like I said, my name is Puti. My talk is focused on typhoid fever in South Africa and some of the lessons from recent outbreaks. So enteric fever, which includes typhoid fever and paratyphoid fever, it is or can be a life-threatening disease. And without treatment, the case fatality rate can be as high as 10%. And with treatment, this can be reduced to about 1%. And the infection occurs mainly through the fecal-oral route, which is basically the ingestion of food or water that is contaminated by the feces of an infected person. The clinical manifestations, so the average incubation period is about 7 to 14 days, but it can range from 3 to 60 days. And the symptoms are non-specific. That is, they overlap considerably with other causes of acute febrile illnesses. However, fever is the main symptom for enteric fever. And other symptoms may include fatigue, headache, nausea, abdominal pain, constipation, or diarrhea. Diagnosis is generally difficult because of the non-specific symptoms. It is usually made by isolating the bacteria from a blood sample, and there are currently no reliable rapid tests. When it comes to carriage, which is a very important component of enteric fever transmission, about 10% of persons who are recovering from enteric fever, they will intermittently shed the bacteria in their feces for several weeks, can even be up to 12 months, and these are referred to as convalescent carriers. And while up to 4% of those who were infected can continue to shed the bacteria for over a year, even more than a year, and these are known as chronic carriers. A well-known example will be Typhoid Mary Malone. So carriers have important implications for public health because they act as reservoirs within the population. And most chronic carriers actually have no symptoms, and up to 25% of them give no history of any acute enteric fever. So when it comes to prevention and control, improved water and sanitation infrastructure, those are the key methods in terms of prevention of enteric fever, the provision of safe drinking water and improved sanitation. And coming to public health measures, accurate and timely diagnosis are key, and appropriate antimicrobial treatment and following up of all these cases to ensure that they do not continue shedding the bacteria, basically ensuring that we do not have carriers in the community is also critical, and also the identification and the treatment of those chronic carriers. When it comes to health education, hand washing, it's key, together with food safety practices as well. Vaccination is only recommended for countries with high burden of disease or with high burden of antibiotic resistant strains of Salmonella typhi. But sometimes vaccination can be used as a control measure in response to larger outbreaks. So when it comes to South Africa, typhoid fever or enteric fever is endemic to South Africa. And we mostly see enteric fever that is caused by Salmonella typhi. There's very few cases of paratyphoid fever in the country. And outbreaks used to be common. The last large confirmed outbreak was occurred in Delmas in 2005, sorry. And after that Delmas outbreak, the number of cases remained stable with less than 150 cases being reported each year, averaging about 97 cases reported nationally every year. However, cases have increased since 2022. We have observed an increase in the number of cases that are being reported nationally. And there were multiple clusters and outbreaks that were reported during this period in between 2022 up to now. So just looking at the trends of the annual cases that have been reported since 2003, we can see, put the laser. We can see the Delmas outbreak in 2005. Over 200 cases, laboratory confirmed cases were reported. And then since 2005 up to 2022, we've been consistently getting less than 150 cases reported annually, averaging 97 cases a year. But then in 2022, we saw an increase with over 200 laboratory confirmed cases reported. And this increase was mainly driven by an outbreak of enteric fever that was identified or picked up in the Northwest, particularly the Klerksdorp area. And that outbreak was associated with illegal miners. We will talk about that as we continue. And the more recent peak that we saw, also over 200 cases were reported in 2025. And this increase was mainly driven by the cases that were reported from the city of Tshwane, particularly from the Hammanskraal area and also Bronkhorstspruit areas as well. But I mean, basically, we can see that since 2021, there's been an increase in the number of enteric fever cases that are being reported nationally. So we'll look at the outbreak investigation in the Klerksdorp area. So around November 2021, we got an alert of an increase in the number of cases in the Klerksdorp hospital at the time. And then we conducted an analysis of all the salmonella typhi isolates that were coming from the Northwest. And we also did CG-MLST just to check how related were these isolates. And almost all the isolates that came from the Northwest for that period, they were genetically identical, which suggested to us that there could be a common source of infection for those cases that were responsible for an increase that was being observed in that Klerksdorp hospital. And we also analyzed isolates from other provinces as well, because as part of our routine surveillance, we get isolates of Salmonella typhi from across the country. So there were other isolates as well that were linking to the isolates from the Northwest. We suggest that even though these other cases were in other provinces, but there could be something that links them to the cases that we were seeing in the Northwest. So our initial hypothesis was that there could be an intermittent contamination of drinking water sources in the affected areas because of the prolonged nature of the outbreak, because it occurred over a couple of years. And just looking at the basic demographics of the cases at the time, we can see, just looking at all the Northwest Province cases, all of them were clustering together. This first figure here shows the cases by the sequencing results. There were only 2 cases that were not part of this cluster. And the first one, understandably, it occurred like 8 months before the outbreak strain emerged. And the other one was a travel-related case. The patient had traveled to Zimbabwe and got ill while they were in Zimbabwe. So it was an imported case. But all the other cases that occurred in the Northwest at that particular time, they were clustering together in terms of whole genome sequencing, which tells us they could have been exposed to a common source. And another striking feature in this outbreak was that adult males were mostly affected compared to any other age group, which was an unusual feature in this outbreak, because we would generally expect the vulnerable groups to be the ones who are mostly affected, like children and the elderly. But in this case, male adults were mainly affected. And just looking at the cases by their geographical area of residence, on this other graph here, you can see they were coming from different areas, which made our hypothesis of contaminated drinking water or municipal water, fall off very quickly, because these people were coming from different areas that uses different water supplies as well. And then other provinces as well were also featured in this outbreak. You can see there were isolates from Gauteng, isolates from the Free State, and also Mpumalanga and KwaZulu-Natal. And then we went to the city of Matlosana to conduct further investigations. The team went there as part of that team, and we conducted in-depth interviews with the cases, and where the cases could not be found, we did interviews with the proxies to those cases. And this is just a summary of some of the interviews that we conducted at the time. So the first patient that we interviewed, we actually interviewed a proxy because the patient had demised. He was a Lesotho national. And so we spoke to the girlfriend of this case, and she disclosed to us that the patient was not at home for a period of 3 months. And by the time he returned home, he was already ill. However, the lady or the girlfriend was not willing to disclose where the partner was. As we were about to leave, fortunately, a friend of the deceased came in, and he was more willing to share with us some details in terms of the whereabouts of the deceased just before he got ill. So he disclosed to us that he was actually with the deceased when they got ill. He was also ill as well, just that he never went to a hospital. He saw a private GP and he recovered. But for the 3 months, September to November, they were working underground. So they were basically illegal miners. and they got ill while they were underground. That's from what he reported. They got ill while they were underground, and by the time they resurfaced, they were already ill. And that's when the one who died was taken to hospital, and he consulted somewhere else. And he also detailed of the type of the water sources that they make use of while they were underground, and also the food that they eat when they were underground. So the next person that we interviewed also reported that he was in the same cohort as the first case. He was also underground working as an illegal miner when he got sick. So obviously these two cases were exposed underground, because by the time they came out, they were already sick. And I think a more interesting case was a Gauteng case, a case that we interviewed in the Boksburg area. It was a young man. He also reported that when he got sick, he was actually in Klerksdorp, in one of the mines there in Steelfontein. It's just that when he resurfaced, he came to Gauteng to seek for medical attention. So he was also from that province. And another Gauteng case as well was an illegal miner. We spoke to the proxy of this case, which was the sister. She did not know where the brother was, but she knew that he was away for a couple of months, and when he came back, he was already sick. Then they took him to hospital, and she also knew that he's an illegal miner, just didn't know which mine he was working at. But from the data that we have, it is clear that even this case could be coming from the Northwest, could have been working in the Northwest as well. And yet another interesting case was a miner. A case that was seen in the Free State. This was a child who demised, unfortunately. So we interviewed the father of this child, who confirmed to us that the uncle of the child returned from Steelfontein, from Klerksdorp, where he was working as an illegal miner as well. And when he returned, he was very ill, and he stayed with them. And unfortunately, soon after his arrival, the child also developed symptoms. And the uncle recovered, fortunately, but the child did not recover. And another Free State case as well. This case was also a foreign national, or he was a Zimbabwean national, actually. And we spoke to a guy who was basically a handler to this case. So he reported to us that the case came to South Africa around January in 2021. Straight from Zimbabwe, and he didn't really get to stay in South Africa, well, at least not on the surface. So literally after he arrived, he went straight underground and he started working. And he only resurfaced in February 2022, which is 13 months later, and they took him out because he was ill. So even this one was clearly exposed while underground. Well, like in any outbreak investigations, the index case is always critical to understand where the outbreak could have started. So in this case, the index case was a female, was a lady who was a South African national who lived or resided in Klerksdorp area as well. But she reported to us that when she got ill, she was actually in Mozambique. She had traveled to Mozambique with her boyfriend. Her boyfriend is a Mozambican national, so they were staying together. She was visiting there in Mozambique, and they stayed in a very rural area where there was no running water and there were no ablution facilities. They were practicing open defecation, basically. And the area had heavy rainfalls as well, and there would be flooding as well. So the environment was just conducive for the transmission of many other enteric pathogens. So she got ill while in Mozambique, and then they brought her back because she was getting worse in case anything happens. So the second case here, we learned that it was actually the father of the index case. So this was a case of a household contact. And then when we later spoke to the other case, although she was staying in a different area, but she confirmed that she was the sister of the index case. And she actually took care of the index case when she was still sick. So this is basically a household cluster. And it was also reported that the boyfriend of the index case was an illegal miner. So upon his return, with his girlfriend from Mozambique. He actually went underground. He went back to work. And our hypothesis was that since he was never symptomatic, although he was taking care of the girlfriend who was ill, he may have been exposed to this strain before. So our hypothesis was that he's possibly a carrier in this scenario. And then when we look at the overall picture of the other cases that came through later on, we can see here's our family cluster that started. But then 2 months later, after this family cluster, then we had the first case of an illegal minor. So our hypothesis was that the boyfriend, who's likely a carrier, possibly introduced the strain into the mines there in Klerksdorp. And then from then on, transmission continued to other miners as well. And also the contacts of those miners, when they resurface, they come back to the same communities and they interact with these communities. So there would be household contact or household transmission, and even transmission within the community, the broader community as well. So all the illegal miner cases that we have interviewed, they were, their illness onset began while they were underground, which clearly tells us that they were exposed while they were underground. And we learned that, we were told that there are no sources of safe drinking water underground, and there are no ablution facilities as well, because these are abandoned, some of them are abandoned shafts. So this obviously leads to the contamination of the water sources, which is the same water that they use for drinking when they are underground. And they also spend prolonged periods of time underground, up to 12 months or even more. And there's also an issue of overcrowding in these spaces as well. It was reported that over 300 illegal miners could be found in the same mine at any given point in time. And also cases of illness and deaths underground are common occurrences, according to their reports. And we also noted a reluctancy in seeking medical assistance, mainly because most of these people were illegal immigrants, so they would be hesitant to go to hospital and seek medical attention. So most of them would come to the hospital with an advanced disease. Some of them actually required surgery, had intestinal perforations, and so forth. So in discussion, Salmonella typhi enteric fever typically affects young children and the elderly. However, in this outbreak, it affected mostly adult males, which really supports the hypothesis that the minors were the group that was most at risk of infection. And the wide geographical distribution of the cases makes municipal drinking water in this outbreak the unlikely source of infection. And we still continue to see cases that belong to this cluster, actually, even today. And this is likely due to the presence of acutely ill miners in these communities, or chronic Salmonella typhi carriers within the illegal mining communities, which leads to continuous contamination of water sources. So this is just a graph that shows the current picture. So you can see in red, this is really where the outbreak started in the northwest, and it was mainly driven by illegal miners, or most of the cases were illegal miners. And then after all the interventions that were done following the investigations, we believe that the outbreak clearly the outbreak seemed to have went down, at least in the northwest. But then we started to seeing this outbreak strain emerging in Gauteng province. And this was particularly in the Western region. Most of these cases were coming from the Carltonville Hospital, and some of them actually were confirmed illegal miners. So really the hypothesis is that this strain was introduced to other mines, particularly in the Western, and then it continued to spread among the illegal mining communities. So it was crucial to devise a strategy to inform illegal miners of the high risk of enteric fever and provide them with health education, and most importantly, the use of preventive measures whilst working underground. This was basically the recommendations that we came up with following that investigations. And these were just some of the pamphlets that had to be distributed to educate the community on how to make the water clean. We couldn't really target illegal miners per se, but they are also part of the community. So as we educate the community, they would also get the message. And to some extent, we believe this could have helped in curbing the number of cases being reported from the Northwest province. But we continue to see these cases emerging in other provinces as well. So basically, this is an ongoing outbreak of Salmonella typhi associated with enteric fever, predominantly affecting illegal miners, with the ingestion of underground contaminated water by fecal matter identified as the likely vehicle of infection. And we did manage to publish this outbreak investigation in a peer-reviewed journal, and it can be found on the website. Yeah, I'll acknowledge those people and the team, the investigating team as well. Thank you very much.
Thank you very much, Mr. Sekwadi, for your very comprehensive presentation, which has highlighted so many concerns that need to be addressed around typhoid fever in South Africa. So I'm hoping that people will type questions and comments in the chat. This is something that we all need to be thinking very seriously about and addressing. I'd like to move on now to our third speaker, who is Professor Wanda Makota, who is from the University of Pretoria. She is the chair of infectious diseases of animals, and she is also co-chair of the One Health high-level expert panel advising a number of international organizations. We thank you for joining us, Professor Makota, and we look forward to your presentation. Please do go ahead.
Hey, thank you. And I'm definitely not a typhoid expert, so I'm really going to speak on a high level about how all of this fits into some of the One Health and also pandemic. We talk a lot about pandemic prevention, and then we forget about endemic diseases and other outbreaks and how this fits into this bigger picture. And a lot of the previous speakers has already highlighted some of the points that I will also just make again. And I think if we talk about One Health, there's lots of definitions out there. And I think it is important that we recognize what do we mean when we say One Health. And recently, the One Health high-level expert panel revised previous definitions just to make it really more representable of planetary health, of One Health, of some of the other terminology now in one definition. And this figure just summarized it. And it's also important when we think about waterborne diseases that we think about One Health. It's not just when we think about pandemic pathogens. It is really also about these other diseases that we deal with. And it's about bringing all the sectors and disciplines together, as we heard in some of the presentations today, thinking about the healthy ecosystem, healthy animals, and healthy humans. I think previously with One Health, we would test animals and we would test humans, and then we say we're doing One Health. But it's really understanding this broader picture of what is also the drivers leading to these diseases emerging. And I think the previous presentation just showed the complex issues that we deal with that we need to understand if we really want to address outbreaks from happening. And not just testing for pathogens. I think the other important thing with One Health that I've also heard from some of the previous presentations is, who do we bring into this discussion? It's not just public health officials. It is the animal sector. It is the environmental sector. But it's also different levels of society. So we really need to bring communities that's affected by these diseases into these discussions. I've heard community-based surveillance in the previous presentations that fits very well into this. And then also bridging with policymakers, government, and even sometimes global initiatives. So it's really this integrated approach where we need to look at all these different sectors. And we need to recognize if we address these problems, we're actually addressing broader things like clean water, clean energy, safe and nutritious food, even addressing climate change. There's another slide that I want to show, and this was published with the definition. And I think this is some principles that we also need to think about with waterborne diseases that is integral in One Health. Equity is really important between sectors, between disciplines, but also between the society members involved. Socio-political parity, and yeah, the the main principle is really inclusion of engagement of communities and marginalized voices into addressing outbreaks of this magnitude. Socio-ecological equilibrium, we as humans really need to take responsibility to solve some of these issues, and that there's value in all living things in ecosystems. Stewardship and responsibility to do this, and well-being. And then transdisciplinarity is really becoming essential. So it's not just about bringing different disciplines together, it's also about bringing different actors together. And that's where the transdisciplinary component of One Health is really important. So I come from an infectious disease perspective, and we always show this slide, there's a new approach to prevention, preparedness, and response. And here we talk about pandemics. We always just think about all these viruses that you see at the bottom and how they affected people's health over the year. And we say, okay, they're going to emerge again, and they come from animals. But I think what's sometimes missing from this discussion is we also need to think about the outbreaks that's constantly happening in country and the endemic diseases in this perspective also, where we're talking about prevention and preparedness and response to pandemics, because that's what we deal with every day. And that's where we also need to apply a One Health approach. It's not just these pandemic-prone pathogens that needs this approach. So I'm going to go over this very quickly, but this is just making the point that, yes, we can just look at the pathogen and we can test samples and we will know the pathogen's there and we will know the pathogen's not there. But it's really about all these other complex factors, that's all these circles that you can see here, and understanding that to really get to a point of understanding why diseases emerge. And if we understand why they emerge, we can actually address that. And we can address the factors that is leading to emergence that you've seen in several of the previous presentations. So this is just primary drivers of disease. And so many of these are also relevant to what we see with waterborne diseases, not just with pandemic-prone pathogens. Climate and weather, really a big issue. It keeps on changing, breakdown of public health, food industry change, water, agricultural industry, land use, and all of these things is really what is coming into the picture with a One Health approach, together with looking at pathogen prevalence and doing public health interventions. So this is a paper that Ola published that I led, where we really looked at zoonotic spillover. And when I looked at this, because I deal with this picture quite a bit, I realized this is also applicable to how we think about waterborne diseases. So we heard a lot about prevention. We don't always just want to react when people already have cholera or they already have typhoid. Then there's already deaths, people are sick, very difficult to deal with that situation. We also want to move into this little red block on the side, which is about prevention of diseases. So I'm making the point over and over again that we need to understand these drivers that's leading even waterborne diseases now spilling over into people. What is the reasons for that? What's the risk reduction activities that we need to bring in? Integrated surveillance. We can't just look at one aspect, and just wait till it's in humans and test that. We need to test the water. We need to test animals that's leading to contamination of water sources, and the list goes on. And then we will, although we talk about zoonotic spillover here, we will also prevent things like waterborne diseases. And we won't always just be in this preparedness and response cycle where we will prevent a lot of these outbreaks from happening. Probably not all of them, but even if we can reduce the amount of outbreaks that leads to disease, it will already be a big win. So just in the global picture, some of you may have been in talks before where you're aware of this. There was a One Health Joint Plan of Action that was released by the Quadripartite, and this is the FAO, United Nations Environmental Programme, WHO, and the World Organization for Animal Health, already in 2022. So it's already a few years since they've released this, and this is basically a roadmap worldwide for member states on how they can look at One Health in their countries. And this has led to a lot of development on One Health plans in country. And I'm on the One Health Steering Committee in South Africa, and we're currently busy writing that plan. It's almost finished. It is really almost finished, I can say that. And water and food is part of this plan. Because if you look at the different action tracks, and although they are very broad explanations, this is not just about zoonotic and pandemic pathogens. It is about neglected tropical vector-borne, and also about integrating environment. And this is where a lot of wastewater and all that type of work is also relevant. Food safety, water is very closely linked also to food safety, and really enhancing our capacities across so that we have a workforce that can deal with diseases across disciplines and across different actors. So this is what's going on globally, trickling through to national plans, and also in South Africa, these plans are becoming quite prominent. There's also some funding instruments linked to it, and water has been part of pandemic fund discussions, as well as some of the other funding discussions. So there's also an implementation plan. I'm not going to go through all the detail for the sake of time, but this is things that you can go and read up on if you're interested, and it feeds into how we're developing One Health implementation plans also on national level, and that is where it needs to be implemented. The global level can give us all these frameworks, but countries need to decide how it is relevant to their local context, and then even municipality context, district context, community context. So there's really a bottom-up and a top-down approach to implementing One Health. So maybe just this has all been said, so I'm just going to highlight a few points here, but really important to think about what is the transmission pathways so that we can think about prevention, what's driving it, poor sanitation, inadequate water treatment. I heard the strong link to illegal mining also today with some of the typhoid outbreaks, really complex issues that we need to address if we want to prevent some of these diseases and outbreaks in the future. So why does it matter? I think it's really clear that we cannot look at these things in isolation, especially if we talk about typhoid today, where there's this link between human, animal, and environmental health that we really need to consider. We cannot look at it in a siloed approach. We need to think about the disease transmission again. Where does it come from? Where does the pollution in the water come from? And how can we prevent that? And that will require a collaborative approach, not just in prevention, but also in how we do surveillance. How do we monitor this? And then also when we need to control it when there's an outbreak. So there's all kinds of links that you've also, again, heard about. So I'll go through this very quickly, but it's really about the animal and the human that requires really integrated surveillance in the environment. So it's about these three circles of One Health that is crucial in how we address these diseases going forward. Environmental drivers, really important. Climate change, land use, effect of droughts, effect of floods, really influencing, and we're seeing these diseases popping up in areas where it's never been seen before. And it's because of all these environmental drivers and anthropogenic drivers that is just all around us and changing on a daily basis. So the word early warning becomes really important here. If we don't monitor these things and predict, then we will be caught off guard. So we really need to move into an early warning predictive approach. Not the only approach, we also need to be ready to respond and be prepared. But this is part of the bigger picture of addressing disease emergence and also waterborne diseases. So I'm going to stop with the South African context. I've heard a lot of this in the previous talks, and I want to leave enough time for the last speaker to also present. But yeah, One Health is essential, not just for pandemic preparedness, also in all these other diseases that we deal with on a daily basis. I'll stop there.
Thank you so much, Professor Makota, for your very interesting presentation, which was very encouraging to know that so much work is happening and actually that we seem to be moving on the right track. So thank you so much, and I hope you'll be available for questions a little bit later, as all our panelists will be. I'd like to move on to our fourth and final presenter for this morning. She is Dr. Nhlanhla Shimange Masemola. She is a specialist, clinical microbiologist and infectious diseases microbiologist who works at Lancet Laboratories in South Africa. And she has considerable expertise in diagnostic microbiology, antimicrobial resistance, and in laboratory-based surveillance. So thank you so much, Dr. Shimange Masemola, and I hope you can take over and share your screen and start your presentation.
Morning. Sorry, I need to share this. Good morning. Can you see my screen?
We can. Thank you.
Okay. Thank you for the introduction and good morning to everyone. So today I'll be presenting antimicrobial resistance in enteric pathogen, a One Health perspective on typhoid fever control in South Africa. So during my presentation, I will briefly touch on topics already discussed solely to provide context on antimicrobial resistance. So enteric pathogens are infectious microbes such as bacteria, viruses, and parasites, which cause illness by disrupting normal gut function. So these present with symptoms like diarrhea, vomiting, and fever, which has already been discussed earlier on. And then common examples include Salmonella, E. coli, and Shigella. So I won't really go through typhoid fever, but typhoid fever is part of the enteric organisms, and it's caused by Salmonella typhi. So this is a human-only disease. So humans are the only carriers for typhoid germs. The bacteria are excreted in the feces of infected individuals, and transmission occurs via direct person-to-person contact, consumption of food or contaminated food or water contaminated with feces. So patients who are acutely infected can transmit this. Patients who are recovering can transmit this, and patients who are chronic carriers can transmit this. So just a brief introduction on epidemiology. So this has already been discussed, but I need to discuss this just to lead to antimicrobial resistance. So there's 10 cases annually worldwide, and more than 100,000 cases, deaths worldwide. And typhoid is endemic to South Africa. So how do we treat this? So pre-antibiotic era, the mortality rates of typhoid fever were about 5 to 20%. And then we got into the antibiotic era where the first line was chloramphenicol, ampicillin, and cotri, and then the mortality rate decreased. And we started having multi-drug resistant organisms, which is organisms resistant to all three first lines. And then that's when we started depending on ciprofloxacin. So ciprofloxacin is a very good drug. It gives rapid resolution and it eradicates carriage. But the issue is we are seeing organisms that are resistant or non-susceptible to ciprofloxacin. And in these organisms, we rely on cephalosporins, specifically your third generation cephalosporins, such as your ceftriaxones. So what is antimicrobial resistance? And so antimicrobial resistance is the ability of microorganisms to resist antimicrobial drugs, making standard treatments ineffective and allowing infections to persist and spread. So this causes increase in deaths. And if you look at this, deaths from drug-resistant infections are projected to rise sharply, reaching an estimated of 10 million annual deaths by 2050. So this is a lot. So as compared to 2020, where deaths caused by antimicrobial resistance were 1.3 million. So how did antimicrobial resistance start? And so antibiotics were introduced in the 40s, and they helped a lot of patients, cured a lot of infections. But as soon as they were introduced, we started getting resistance. And to curb the resistance, and we started introducing and discovering more antibiotics. But with more antibiotics being discovered, and we are seeing that, and we're getting more resistance to all these antibiotics. So we are heading into a post-antibiotic era. So the World Health Organization created the priority pathogen list to identify bacteria that pose the greatest threat to human health because of increasing antimicrobial resistance. Salmonella, resistant to ciprofloxacin, which is currently our first-line drug, and in South Africa, is classified as a priority pathogen. So emergence of multi-drug resistance started in the 80s, and where it's resistance to ampicillin, chloramphenicol, and cotrimoxazole. And in South Africa, we are seeing these organisms which are resistant to cotri and ampicillin and chloramphenicol. And so we are seeing multi-drug resistant salmonellas. And then as soon as we started seeing multi-drug resistant salmonellas, and we started using fluoroquinolones, specifically ciprofloxacin. And as soon as ciprofloxacin was introduced, other areas worldwide, they started seeing higher level resistance to fluoroquinolones, to ciprofloxacin. But in South Africa, we do see salmonellas that are non-susceptible to ciprofloxacin, but it's not high level resistance. And in 2016, there was an outbreak in Pakistan of extensive drug-resistant salmonellas. So this is a salmonella that is resistant to all first-line drugs, resistant to ampicillin, chloramphenicol, and cotri, plus fluoroquinolones, so meaning resistant to ciprofloxacin, plus third-generation cephalosporins, and meaning resistant to ceftriaxone. So 5,000 people were diagnosed with XDR. And the only options that they were left with, the oral option was azithromycin, which is the only oral option that we have for salmonella, and bigger antibiotics such as your carbapenems, which are the best antibiotics that we have and for drug-resistant organisms. So the current trajectory is in South Asia, ceftriaxone and cefexim are nearly 100% resistance, and we need to try and prevent that from happening in South Africa and in Africa as a whole. So what do we see in South Africa? So this is from NICD. So this is a surveillance of enteric fever. So this is a report of all the organisms and from 2003 to 2023. So if you look at this, chloramphenicol, which was used previously and was highly susceptible, but towards the end of 2023, and we didn't see any isolates that were susceptible to chloramphenicol. And then we are seeing ciprofloxacin susceptibilities that has declined and become unstable, so often falling below 80%, and which is something that we don't want to see. The good news, although not so much good news, is our carbapenems are still 100% susceptible, and azithromycin, which is the last oral option if we have resistance to ciprofloxacin, it's still 100% susceptible. So how does resistance occur? So resistance occur mainly and from a target mutation. So target mutation means, and if a drug, so ciprofloxacin binds onto the organism, and then when it binds to the organism, it stops the organism from replicating and it kills off the organism. So the organisms, and these organisms become smarter, and then they develop mutations, and therefore ciprofloxacin cannot bind to them. So there is double mutations on a certain area called GRYAA and PAR-C, which lead to high level resistance to ciprofloxacin. And we also have efflux pumps. So efflux pumps is when an antibiotic gets into the organism, and then as soon as it gets into the organism, it's pumped out. So if it's pumped out, it cannot work against these organisms. So 98% of isolates have active efflux pumps. So there's also acquired resistance and via plasmids. And so these are horizontal acquired resistance. So plasmids are resistant determinants that are packaged in gene cassettes. And so the plasmids has a broad range of broad host range, meaning you can get a plasmid that is in an E. coli, and then it's shared from an E. coli to the salmonella via the pili. So these organisms share these plasmids, and so meaning they share resistance. So we don't want to see this, hence the One Health approach. So these plasmids usually carry resistance to your third generation cephalosporins and additional resistance to ciprofloxacillins. So this is what we don't want to see, and this is what we are seeing in other enterobacteriales such as your Klebsiella pneumonias, such as your E. coli. But fortunately, our salmonellas, we're not seeing this. So there's an H5 emergence, and so this is the strain that has swept across Asia and Africa, displacing the local strain. So it is the primary vehicle for multi-drug resistant salmonella and extensive drug resistant salmonella. So this strain has a plasmid, and then this plasmid carries the CTXM15, which is responsible for resistance to your third generation cephalosporins, and it also carries a mutation, and which is causes resistance to your ciprofloxacillin. So this is what they are seeing now in Pakistan and some areas in Africa as well, including Malawi. So the diagram shows the One Health ecosystem, a cycle of reinfection. So humans are the only natural host for Salmonella typhi. So chronic carriers shed the bacteria into the environment, lacking sanitation, and untreated sewage contaminates water supplies. So these water eventually gets used in food crops, and then humans are reinfected again. So the constant reinfection increases in antibiotic use, increases resistance pressure, and then resistance strains spread through the environment all the time. So agriculture. So why am I talking about animals as well? So I'm talking about animals, although I said salmonella is a human-only disease. So the reason I'm talking about this is because they are all enteric bacteria. So if you find a salmonella in the gut, and then you find an E. coli in the gut, and that's not causing a salmonella, if these come into contact together, and then they share the plasmids that I spoke about, the plasmid that carries resistant determinants, and so the plasmid that carries CTXM15 and other resistant determinants, and the salmonella becomes resistant. So the same thing happens in the environment as well. And if you have salmonella species that are different from Salmonella typhi and carrying resistance, or if you have E. coli carrying resistance, and in the environment as well, these organisms can share horizontally and these resistant determinants. So how do we control this? And so the easy answer is, and we need safe water access, we need good sanitation, we need food hygiene, where we teach patients to wash, hand washing with soap and water after using the toilet and before handling food. And people with typhoid should not prepare food until they are confirmed free from infection. So One Health approach recognizes that humans, animals, and environmental health are linked. So solution must involve all sectors. So some antibiotics are still registered as stock remedies, allowing over-the-counter use of antibiotics without prescription. So this practice contributes to antimicrobial resistance. The National Antimicrobial Strategy Framework promotes responsible use of antibiotics in animals using a One Health approach. So I won't really go through that because it's already been discussed, but I just wanted to highlight why we need a One Health approach. So we need health in humans, health in animals, and health in the environment, because these organisms are very smart and they turn to occur together and share resistant determinants. So there's another way of controlling the spread of Salmonella typhi. So prevention of typhoid reduces disease and resistance. So with fewer infections, we have fewer antibiotic usage. So there is a typhoid conjugate vaccine, and which is a game changer. So this vaccine provides long-lasting immunity and are effective in young children. So countries that have introduced these vaccines have seen a significant reduction in typhoid incidence. So these vaccines have also been used in outbreak responses, and they have helped a lot. And then I want to talk about WASH infrastructures. And so Dr. Joasha has elaborated on that. Another important thing is antimicrobial demands agricultural regulation, environmental monitoring, and intersectoral collaboration. So surveillance must be integrated across these sectors to detect resistance early, monitor environmental contaminants, and guide public health response. So what do we do in the health sector? So what we do in the health sector is, and we do prompt diagnosis. So prompt diagnosis using blood culture and an appropriate clinical management. So appropriate clinical management involves empiric therapy. So when a patient comes in and we've diagnosed them with salmonella, either clinically while we take samples, blood cultures. So what we do is we put them on triaxone, so third generation cephalosporins. Why do we do that? Because we've seen in South Africa sensitivity to ciprofloxacin sometimes falls below 80%. So you don't want to give a patient who is sick something that might not work. But as soon as we get susceptibility and we get these organisms are sensitive to ciprofloxacin, then we de-escalate to ciprofloxacin. So we follow up these patients to make sure that they're not chronic carriers. And if they are chronic carriers, then we have to treat them and to eliminate this carriership. And then we do health education as well. If there's outbreaks, we do health educations, and then we do health educations regarding antimicrobial usage, antimicrobial stewardship as well. And what's important as well is to know that Salmonella typhi is a Category 1 notifiable medical condition in South Africa. So environmental sector, I'm not going to talk about that, but intersectoral collaboration is very important. The Department of Health needs to treat these patients appropriately, diagnose them appropriately, and notify them appropriately. And then Department of Water Affairs as well needs to make sure that there's access to safe drinking water and improve sanitation. And we also need to involve other sectors, so sectors such as the agricultural sector, because we've seen that these organisms, although they are in humans only, they can acquire resistance from other organisms that are in animals. So in conclusion, typhoid fever is preventable. Antimicrobial resistance threatens typhoid control. So the One Health approach is critical. So we need to strengthen the One Health surveillance and improve WASH infrastructure in the community and promote rational use of antibiotics and support vaccination. Thank you.
Thank you so much, Dr. Shimange Masemola, for a very comprehensive presentation, which has raised many, many issues that we need to address. I don't see any questions in the chat. So we have 3 minutes left of the webinar. If there are any pressing issues that anyone would like to raise or pressing questions that you would like to address to any of the speakers, please do type it in the chat or raise your hand, and we would like to give the speakers an opportunity to address them. Good, so if you could help me to check hands if you see any that are raised.
There is a question in the Q&A. Are there ongoing monitoring and surveillance for core risk areas and other waterborne pathogens?
Thank you. The question is about ongoing surveillance. I'm not sure which of the panelists would like to address that one. Maybe our last speaker, Dr. Shimange Mosimula?
With regards to water surveillance, I think Dr. Joshua is actually maybe the correct person. But with regards to surveillance in patients, and so what happens is every time we culture a Salmonella typhi, we send those isolates to NICD, and NICD does sequencing, as far as I know. Phuthi can elaborate on that. But in healthcare centers, we know Salmonella is a notifiable, category 1 notifiable medical condition, meaning we need to notify it as soon as possible within a day. So that's what we do. So we notify via the laboratory, we notify via the clinicians as well. And so that's what we do. So that's how we do surveillance. And with regards to antimicrobial resistance, and so there's laboratory-based surveillance where we check all the escape organisms, specifically resistance to your Enterobacterialis. And so we pull out the data and we check and the percentage of your ESBLs, for example, in E. coli. So ESBLs meaning organisms that are resistant to your third generation cephalosporins. And then, with regards to Salmonella, if someone wants us to actually pull out that data, we are able to pull out that data as well, and then tell them, okay, we have this number of Salmonellas, and there is how the resistant patterns as well. But NICD and have all the isolates and sent to them. So I don't know if Phuthi would like to just elaborate what they do with the isolates as soon as they get to NICD.
Thank you, Dr. Masamala. Yes, I can add to that. We do have surveillance for enteric fever and other enteric pathogens. So as mentioned, it is a notifiable medical condition. That means whenever there's a diagnosis of enteric fever, that case gets notified through the NMC, and then isolate comes to the NICD or gets referred to the NICD. And here the NICD, we do a number of tests. We also do ASTs as well, just to monitor the antimicrobial susceptibility. And we also, we do whole genome sequencing. That's how we detect some of these outbreaks. When we see isolates that are related, then we liaise with the Department of Health official, and then then the outbreak investigations will start from there, looking at those isolates that are related. So we do it's a very comprehensive surveillance system that we do for enteric fever. Although it's only based on laboratory diagnosed cases, but that is most of our cases are laboratory diagnosed, and we do get isolates from both the public and the private laboratory as well. And we monitor them on a regular basis. We look at the data, see if there are any changes in terms of the trends, if there's an increase in number of cases in particular areas, and if we observe any increase, then we institute outbreak investigations to try and find out what could be the cause of any increase if there is such. Thank you.
Thank you both. Dr. Jaswa, do you want to respond about water surveillance?
Yeah, so I think in terms of our water surveillance, we do have, I think, wastewater surveillance that is now becoming a tool that different provinces are using. I know Western Cape definitely is using it, but it's still almost at research level, let me put it that way. But usually what happens is, if there's an outbreak, is when we now start looking at our water sources for particular pathogens. In terms of just normal water monitoring, if water supply doesn't comply to SANS 241, then you are supposed to deal with it immediately. So E. coli is our indicator of choice. If the E. coli level is higher and total coliforms level is higher than the recommended amount, then something has to happen, especially if there's now an outbreak associated. So it's almost always after the fact, let me put it that way. But what we are trying to say, I think, with this webinar is the fact that we need to now sort of identify hotspot areas. So places where you know there is a breakdown in your wash infrastructure, maybe then more monitoring and more surveillance must happen in those areas. So I think that's what we're trying to push for here. And it has to be a coordinated approach, because right now the monitoring is still very, very siloed. Clinical on one side, food safety on the other side, because I know food surveillance of Salmonella typhi is also very strong in South Africa. And then environmental surveillance is really on a case-by-case basis, but identifying different hotspots and informing municipalities, for instance, that look, this is a hotspot area. You know, there's a breakdown in wash here. There's a breakdown in water supply. There's movement. So, for instance, I think Puti really described it nicely. The movement of people as well. You know, during travel periods. You know, those are times when you have to monitor more aggressively, because even if you have human-to-human transmission, if people go into an area that the wash services are not available, then you now have bigger spread. So I think the whole idea of monitoring in a very holistic, in a One Health-based manner is what we are trying to drive here.
Thank you, Dr. Jazwa. Kutso, do you see any more questions or hands up?
None on my end.
I don't see any more either. So we have gone a little bit over time, but we did also start a little bit late, and so I think that was fine. I would like to close the webinar now by thanking our speakers for really comprehensive and inspiring presentations. They've given us a lot of food for thought, and it's clear that there needs to be a multidisciplinary, multi-sectoral approach to enteric pathogens and to Salmonella typhi in particular. And I'm sure all of us on the webinar have been very encouraged by what's happening, even though we understand and are committed to all the work that still needs to be done. So thank you so much to everyone for joining. Thank you to ASAF for organizing, in particular to Kutso and Rivoningo. And I wish you all a very pleasant day forward. Thank you, everyone, and goodbye.